部台湾风尘泌尿协会关心你。
好，我们今天会有20分钟的时间让他先讲一下这2个 study， 之后呢，我们会有蛮长，大概30分钟的时间来讨论。这个讨论呢，我们有准备好一些问题，这个问题有11个题目，等一下我会放出来。这11个题目其实都是很尖酸刻薄的。那我们在1个月前就已经传给他了，他看到以后吓一跳，但是呢，他就回去做功课。今天我们看看他最后答案是什么。OK， Eleni，we all welcome you very much. This is the second time she came to Taiwan, but to my memory, I believe you have been here for 3 times. This is the 3rd. Am I right? 杨生的朋友，第2次。Oh, okay. It's my fault. Sorry.
Okay, you mean I was like, I have jet lag.
Okay, Eleni Efstathiou, MD, PhD, is a faculty member in both the Department of Genital Urinary Medical Oncology at MD Anderson, where I spent about a year with Dr. Logothilis. 这个主任是 Dr. Logothilis。我那个时候在 MD Anderson 其实不是在泌尿科，是在 GU Medical Oncology， 在里面耗了1年。She is also a faculty in Greece, so she has dual appointment both in the USA at MD Anderson and also in Greece, Athens. She's main scientific interests are in the areas of prostate cancer, of course, specifically androgen signaling. She is conducting translational research in the high-risk, locally advanced setting and in the far advanced CRPC setting of androgen signaling inhibition in combination with other microenvironment targeting agents. Probably next time you're going to talk about this. This is very interesting. So let's welcome Eleni.
So thank you very much for having me, and I'm very sorry that I have a little bit of jet lag. It's like 4 a.m. in Houston right now. That's the time I wake up though, so I'm waking up. So the first presentation was very interesting and very close to heart, and it's one of the things that we're all struggling with. But this presentation here, where we're going to debate the new data that has evolved in the non-metastatic castrate-resistant prostate cancer, I think gives us the opportunity to learn even more, regardless of whether some of us will agree and adopt it or not. Just to give you a prelude, I was just at the ASCO meeting, and some of you were there as well, and I presented some data in the M0 hormone-naive prostate cancer. You will see me call it hormone-naive and not hormone-sensitive, because when you say hormone-sensitive, you're considering a priori that it will be sensitive, and I try to be more agnostic. So in that trial that I just presented, I actually was at first not sure, but then found out that if you add to an intermittent schema a drug like abiraterone or any of these that we're going to talk about, you get a much lengthier time to recurrence with a eugonad state that was equivalent to ADT alone. That could eventually translate to an improved quality of life for our patients. So I think there's going to be a lot of data evolving in the M0 hormone-naive space as well, because there are trials are going that may improve the quality of life of our patients. And we're going to talk about quality of life in this presentation as well. So non-metastatic castrate-resistant prostate cancer. Does anybody believe that there is such a thing? I mean, it's just a fake state as well. It's just that we can't see it. Obviously, there's disease somewhere. But we have elected to call that, and we have a definition. The definition is that you must have a well-controlled serum testosterone, well below 50 nanogram RDL. Some of you will say 20. I won't argue that. And then by conventional imaging modalities, CAT scan, bone scan, you have to have no evidence of metastasis, and we know the sensitivity of these scans is about 30%. So One thing I wanted to point out is that in the United States, and the physicians who were there for years may remember that, the dosing of LHRH that we use is double the one of the rest of the world, which is more profoundly depleting for the quality of life, just as a side note. So let's focus on this part of the non-metastatic. We know in the MCRPC well now that there are multiple agents that work, including abiraterone acetate and enzalutamide. You are very familiar and use these agents. So let's go to the next slide here. There we go. One of the main considerations, and it's back from the 2000s for those of you who remember those papers, was actually that we have to figure out a way to measure the risk for metastases. And that data suggested that doubling time may be the most low-hanging fruit to use. If you have a doubling time that's over 1 year, the chances of the disease being imminently aggressive and threatening for survival are slimmer. When the PSA picks up speed, you will see that the risk of metastases is much higher in all the publications. Local regional disease progression, quality of life, symptoms, morbidity, and of course survival are affected. Undoubtedly, PSA doubling time, at least for more simple-minded Texans, is not an easy task. So I don't spend the day in the clinic calculating PSAs. I kind of roughly estimate how fast it is progressing. I don't know, do you employ PSA doubling times with accuracy here? I'm sorry? Not like, yeah, just when you don't do it standard for all patients. We don't either. But the trials that we're going to talk about actually used PSA doubling time as the main eligibility criterion. The first study that you are familiar with is a study on apalutamide in non-metastatic prostate cancer that is, per the FDA label, rapidly progressing. It is published in the New England paper and is written very, very nicely and simply, and it's a paper that I enjoyed reading. Apalutamide is the little sister, I call it, of enzalutamide. I call her a sister because she still penetrates the brain barrier, but not to the extent of enzalutamide. What we know, it's also a child of Charles Sawyer's, and what we know from preclinical data is there was a comparison between the penetration in the brain of enzalutamide and apalutamide, and in the animal model that was used, it was 1/6. Obviously, we will not know exactly what transpires in the human condition. So when the trials on apalutamide started, we were hopeful that we would see less of that fogginess and fatigue. The data speaks to that, but unless you start using the drug, you cannot really have a feel. The drug showed, of course, a very, very good efficacy, very similar to what we know from abiraterone and enzalutamide. Nobody can make a claim that any of these three drugs is better than the other. The nuances are very small, and we have to be very honest. The honest part is that we have now 6 phase 3 trials using novel androgen signaling inhibitors. All of them have been super positive, and that is the strength of the novel androgen signaling inhibitors, not the antagonism. Spartan trial. I wonder why they called it Spartan, because Spartan refers to something very, very, kind of laconic. This is not. This is more affluent than Spartan. So the eligibility was, you had to have, by conventional criteria, non-metastatic, castrate-resistant prostate cancer. Having said that, you could have local disease. Anything below the iliac bifurcation is considered local regional, so it is within the indication. Patient had to have castrate levels of testosterone, and of course be in a good performance status 0 and 1, and the PSA doubling time had to be less than 10 months. This is what the FDA mandated for both trials. The stratification included the PSA doubling time, less than more than 6 months, and also the use of bone-sparing agents, and this is interesting, it's almost ironic, and the presence or not of lymph node disease. The stratification actually will be something that we'll get to when we look at the forest plots. The randomization was 2-to-1, and that affects the statistical planning, and it was an ethical consideration. Because 2, you would give a drug that you knew was active, 1 was going to be placebo. The primary endpoint, metastases-free survival, which was a first that the FDA approved, and it was really supported by data coming from pooled meta-analysis suggesting that there is a very strong association between metastasis-free survival and overall survival. Now, having said that, some of you are already thinking, well, then why didn't they approve a denosumab? One has to take biology into consideration. And admittedly, we know for a fact that androgen signaling is one of the nodal pathways of progression of prostate cancer. We cannot say the same thing precisely for the bone, which is the host, even though we assume. And the data coming from denosumab, if you remember, was much more limited with regard to the width of the positive outcome. Now, one important aspect of this trial was, upon progression, patients were offered abiraterone. The physician could decide which agent to use, but all patients were offered abiraterone. So think about it, the placebo ones would go on a very active agent, so all of a sudden, on the secondary endpoint, the trial becomes a comparison of early versus late that we were talking about. And then there was the calculation of the second progression. Randomization, metastasis-free survival, primary endpoint, second progression. First time reported in such a regimented fashion. Primary endpoint, metastasis-free survival, was actually very modestly calculated. They were looking for a benefit of only 30%. I don't know how they would have gotten away with a registration with 30% incremental change. Thankfully, it was not that low. The secondary endpoints, time to metastases, which is just metastases, whereas MFS includes deaths, and progression-free survival, which for me is a very important endpoint because it also includes a local progression. Overall survival and time to cytotoxic chemotherapy and symptomatic progression were included. I'm always struggling with why time to cytotoxic chemotherapy is an endpoint because it varies so much in practice, and some physicians just enjoy delaying it, thinking that they will offer more quality. But at the end of the day, chemotherapy, as we just discussed, may be also a very important player in the tools that we have to fight this disease. And the exploratory endpoints that we already discussed. Well balanced as 2 arms. Older patients with a median age of 74. I want to mention here that the higher age that was recorded was 97. There was a patient who was recruited at that age. The median time from initial diagnosis quite long, about 8 years. The median PSA doubling time quite low at 4.5, with most of men, 70%, at the less than 6-month mark. This is the disappointing part. How bad we follow our patients. 10% were only on bone-sparing agents. The use for osteoporosis prevention, I'm not talking about high dose, and forget about giving vitamin D and actually educating patients to do strength training. 15% of men had local disease. Another thing that is quite disappointing is, remember, to go on this trial, you had to be in good clinical condition and have a good survival expectation. 23% of men had not received prior definitive local therapy, even though obviously they had only local disease. And these were pretty high-end sites that were participating, suggesting that we have still quite a bit of education ahead of us. Interestingly enough, as you would probably saw on the previous, 72% of men had received bicalutamide, but we don't know if that was only 30 days or until progression. The primary endpoint was not only met, it took everyone by surprise because it was more than double what was expected. 72% improvement versus projected 30%, with a difference between the two arms that is a little over 2 years for metastasis-free survival. So we're looking at a placebo of about 16 months to progression by metastases or death, and to 40 months with apalutamide. And this is all pretty straightforward. And then come the questions. What is the impact in quality of life? And what would happen if you treated the placebos with the active agent? And these are the most important considerations in my mind. So this is not working, let's do it that way. Secondary endpoints, exactly the same, suggesting that there is even a good impact in the local disease. So pretty impressive data. And everyone in the room when GU ASCO was presented was not too surprised because I believe they expected it. This is the benefit across all subgroups. As you can see, there is really no difference. Now, there's a little bit of trend for the blacks, which has not been explained, but they were a very small subset. We just heard actually from Susan Hallaby that the black race from the meta-analysis of different trials did not seem to be performing bad. So we expect to hear more data on them since we know they have an aggressive disease. Time to progression, symptomatic progression, thankfully have not been reached, but you can see already the differences evolving. Overall survival, very early, thankfully. I don't think that the placebo will stay here. It will probably, because of censoring, we see this, it will probably go out. I would expect them to live longer. So we'll see how that evolves. Subsequent treatment. Now the important part, we're getting to the PFS2. As you can see, because the placebo patients were half, they actually got, 68% of them actually got treatment subsequently with either abiraterone or enzalutamide. That's a pretty big number. And I want to remind you, in 302, we had something similar. Patients who progressed went on abiraterone, and we still saw a bigger difference. So here's PFS2. So now, time 0 is when patient is randomized, and down here is when patient progresses after the second drug is added. And you still see the curves separate. This is the first clear with a hazard ratio of 0.49. This is the first evidence. Forget any difference between apalutamide and abiraterone and enzalutamide and what have you. That earlier is better than later. Time to PSA progression, come on, this is a no-brainer. We're just looking at it to feel more comfortable. I mean, that's what we expect. Quality of life. Now, this paper is going to come out in about 2-3 weeks. It's in the final throes. And for a lot of people, it's actually a little bit of a puzzle. Remember how they measured quality of life. Very simplistic FACT-P and EQ5D questionnaires, nothing very fancy, which focus on whether the addition of an active agent compromises quality of life. It is completely unlinked from progression of disease. Why? You would fill out the questionnaire as long as you were on the trial and not having progressed. So your control, which is the placebo, is men who remain without any progression. So they start as 400, they go to 300, they go to 200. At the end of the day, you see that the lines remain at the same level. So whether you're giving placebo or an active drug, the patient doesn't feel compromised from the impact of the drug itself. This analysis does not speak at all to the progression of the disease because these patients are removed. Treatment-associated adverse events. Fatigue difference from placebo was about 9%, to be expected, right? But there was something new that we didn't know. This drug causes a rash, and it's a macular or maculopapular rash that is sometimes itchy for the patients, and it can be more extensive. This drug, remember, actually has similar pharmacokinetic profile with enzalutamide. It takes about a month to reach steady state. And it takes about 5 days or a week when you stop to be fully eliminated. So if I get that effect, I usually just give an ointment over the counter, that's a corticosteroid one, and a mild antihistamine, and it takes care of the situation. If it gets worse, I do stop the drug and may resume at 3 pills instead of 4, which is the full dose. But I have not had but one patient who had allergies to 15 antibiotics who I stopped. Now, the rash is not going to be an issue. What I actually thought was a very good readout was the weight loss, because it was not accompanied by loss of appetite. So this may be the first time we're seeing an actual hormonal agent that will not cause weight gain, or we might need to entertain the idea that there may be some extra sarcopenia that we need to look at. So I think we need to study that, and this is a very interesting, small and easy thing to do. Which takes us to falls and fractures. A lot of people, when we discuss falls and fractures, immediately think, oh my God, it's going through the brain, it's causing dizziness. Did not. This was falls, regular falls, and the reason is loss of muscle. And we see it also with enzalutamide. The problem is that these men are also getting much faster osteoporosis, and we're not good about taking care of it. So I think that this is a learning curve. Hypothyroidism, 8% clinical, 25 lab. Why? Because the drug actually increases the metabolism of thyroxine, and we should start thinking about enzalutamide as well, because we never tested. They have very similar metabolism effects on CYP3A4. Seizure disorder. You can't have a drug that passes the brain barrier without looking for that. Interestingly, cabazitaxel passes the brain barrier, and I haven't seen any seizures. But in this case, we saw 2, and I asked about the patients. One of them had actually a history of seizures as a child after meningitis, and it had not been picked up when they were doing the registration, and the other one has not yet been explained, and it was when he had just finished treatment, and he was not associated with progression. So, conclusions. Undoubted, decreases the risk of metastases or death by 72%, and this primary endpoint is supported by all secondary endpoints being hit, with the exception of overall survival because it's too early. That data was presented on the 8th of February, and then the FDA gave Janssen a little Valentine's gift and approved it on the 14th of February. I actually prescribed the drug on the 15th of February, and my MD Anderson pharmacy called me and said, no, there is no such drug. And then I said, look again, and they found it. So the drug is new. Most physicians in the United States yet haven't wrapped their minds around it. It's really, really new. But this is not new. This is enzalutamide. So we know enzalutamide quite well. And I have to say, in my Greek site, I was part of this trial. And it was the time that I was transitioning, but I had about 12 patients on it. The biggest difference between these two trials is the fact that apalutamide was a newcomer that was not registered, not approved, whereas enzalutamide comes in with the air of approved agent, which means that there will not be as regimented a follow-up and monitoring, because we are familiar with the side effects of the drug, so the FDA does not mandate such a strict follow-up. And we will talk about it. I'm saying it because we'll come to it. The study design is almost carbon copy. I mean, if you look at it, it's exactly the same. We even have the same strata, less than 6 months or 6 to 10. And you had to be overall with a PSA doubling time less than 10. Even the randomization, 2 to 1, enzalutamide versus placebo. The primary endpoint, MFS. Exactly what you saw in Spartan. The only difference is 1 month follow-up for Spartan, 4 months follow-up for Prosper. Baseline characteristics. One could argue that the PSA doubling time is a little lower, but more or less the same. 4.5, 3.8, 3.6. Again, most of men in the PSA doubling less than 6 months, performance 0, exactly the same median age. I mean, if they put just the slides up without telling you, you would have difficulty understanding which trial you're looking at. They had a different way of presenting adverse events, and they focused more on the grade 3. And if you looked at their poster, you would find their fatigue, which is about 35%. We know very well that it's very difficult to capture fatigue and asthenia unless you are in the practice following the patients continuously. Adverse events of special interest, something I did not bring up while looking at apalutamide, it's exactly the hypertension. We see hypertension even with these agents. It's not an exclusive abiraterone event. And actually, I think in the enzalutamide case, in some cases, it's centrally driven. Primary endpoint, as good as can be as well. 36.6 months to favor enzalutamide versus 14.7. We won't go in the 4-month difference in the the deltas are the same. The subgroup analysis to favor an all enzalutamide. Too early for the overall survival. I'm being repetitive here. Just the same data. And that's the beauty of it. You have two back-to-back trials that are showing exactly the same things. They did not have PFS2. They did not have, as usual, the monitoring. Sure. Well, what we know is that, again, with this agent, we have a 71% reduction in the probability of developing a metastasis. And the secondary endpoints, including quality of life, were actually met. Now, both are very positive trials. Let's look a little bit at the differences. Monitoring every 1 month, monitoring every 4 months. Grade 3 adverse events, they look a little higher on the end of APA and placebo versus ENZA and placebo. The monitoring, that's what it is. You're looking more carefully. Serious adverse events, very close, no differences here. How about adverse events leading to death? 2% plus. This is where it gets a little bit strange, and we'll talk about it in a bit. Death without documented radiographic progression. 3.3 per apalutamide, 15 for enzalutamide. We're going to talk about it during the discussion, but I will a priori say that until we see the paper that will be out in a couple of weeks, I think, at the New England or Lancet, I'm not sure, we can't come to conclusions. Also, I think that the main educational message from this is monitor the patients. Don't leave them every 4 months. That's what I would have to say. And at the end of the day, we are making progress in prostate cancer therapeutics, and we just discussed the other nuances, cost, the specific populations, and that we have a role as physicians, which is to make the most of this data and adapt it to the practice that we have with what is available to us, monitor the patients diligently because details such as vitamin D and the like matter, listen to the patient and the wisdom that at his age he has to offer to us. Because we are very privileged to be able to offer this to the patients. It's extremely gratifying, so we better be up to honoring it. Thank you very much for your attention, and this is my key.
Okay, the
So, what do we do?
30 minutes, we're going to have a discussion on predefined.
台大 A 院泌尿部，台湾风尘泌尿协会，万幸1。